So good evening and welcome to members, officers, colleagues and members of the public as well as press that are joining the meeting this evening, the meeting of the Health and Wellbeing Board taking place this day on Wednesday, the 26th of April 2023. I can't see any members of the public or press in the public gallery, and for those that may be following this meeting of the Health and Wellbeing Board via the Council's YouTube live stream, welcome. Just wanted to advise that any member of the board unable to join the meeting in person is able to join remotely. However, they won't be able to move or second a motion or vote, and a motion in this instance being a paper that's coming to the Health and Wellbeing Board this evening, and they won't be able to vote or agree or approve if there is a requirement to make a decision on any recommendations that have been made. And just in terms of meeting etiquette, if we could kindly introduce ourselves if you are speaking to either a paper or you wish to comment, so that colleagues that are online and members of the press and public watching know who's talking to what item and what issue. And then also for those colleagues that are joining via the Zoom functionality, the chat function it's going to be monitored during the meeting. So please could you kindly raise your remote hand and we'll keep an eye for that. So the first thing as we progress, need to receive apologies that have been formally sent by members of the Newham Health and Wellbeing Board, and I note that we have received apologies from Councillor Joshua Garfield, who is the Cabinet Member for Education here at the London Borough of Newham, Councillor Sarah Ruers, who is the Cabinet Member for Children's Services at the London Borough of Newham. We have apologies from the Director of Public Health and Interim Corporate Director for Health for Adult Social Care, Jason Strelitz, but his deputy that will be joining us is Adeola Agibiyi, and I'm so sorry, Adeola, if I'm completely messing up and mashing up your surname, and I need to learn, but Adeola will be deputising in the absence of Jason Strelitz. Then we have Simon Ashton, apologies, and we've got Tom Ellis, his colleague, who is going to be deputising, and Tom Ellis is the Director of Strategy. And then we've also got apologies from Joe Fraser-Wise of the Newham Health and Care Partnership. And we also have apologies from Veronica Awuzadeke, who has left Health Watch Newham, and the name of the replacement board member is waiting to be received. So we haven't received it as yet. Okay, are there any other apologies that we need to note?
I've not been given any more, Chair.
Okay, anyone else note any? No? Okay, fine. So if I can just draw everyone's attention to declarations of interest that are set out on pages 5 and 8 of the agenda pack that's been circulated to board members and published for the purposes of members of the public and press being able to access. Can I just receive, for those members of the board present, if there are any declarations of interest covering disclosable pecuniary interest, disclosable pecuniary interest, pecuniary interest as it pertains to matters that we're going to be discussing this evening? Are there any? No, that's a no. Then we are going to now go to the minutes of the meeting that was held on the 1st of February 2023, and that's out in big page number 9 to 13. And I wanted to invite members of the board to advise if there are any inaccuracies or amendments that need to be made before we then move to note, approve that the minutes record the proceedings of the Health and Wellbeing Board held on the 1st of February. So I'm going to just open out to all members of the board. Are there any comments relating to the presentation of the debate as set out in the minutes? I'm seeing lots of shaky heads, and I'm just quickly check if there are any raised hands. Can't see any raised hands. And then I'm going to just see approval on part of colleagues of the board that are here present to agree that the minutes as presented across pages 9 are a correct record of the meeting of the Health and Wellbeing Board for the 1st of February. Is that correct? Yep. That's approved and agreed. Now we have the first substantive agenda item, which is a standing item, and our colleagues from Health Watch Newham will be presenting the community listening ears approach. So who's going to be presenting? Yeah, you want to introduce yourself?
So good evening, everyone. My name is Farhin Ambia. I'm an engagement officer for Health Watch Newham. So I'm pleased to be here to share our findings on the community listening ears pilot.
Great.
So this community listening ears is a grassroots-led community engagement program, which was initially proposed by our volunteers. This pilot was inspired by our volunteers as they felt that a lot of voices haven't been heard and that they want to further our engagement. So we decided to take a deep dive, and looking at our previous work when it comes to mental health support groups, we realized that communication and lack of flexibility, which was the most common cited concern. So this had inspired us to focus on mental health. So we collected our data from December 2022 and it finished in February 2023 for this program. Apologies, everyone. I think there's an issue with the...
Is the slide deck moving, Lynn? Oh, are you sharing your screen? Would it be easier if Pauline, you shared the slide deck? Just in terms of committee management of papers.
Yeah, you can circulate slides to everyone.
Yeah, and just for future reference, so that we avoid these kinds of issues, any papers that need to be shared on the screen, ideally they should always go to the clerk to sort out. Yeah.
Thank you, Chair.
Yeah.
Go to the previous one. Yeah. Yeah, so we wanted to test this approach as we believe it will be great foundation for our future piece of our work. And we do believe that community listening is an authentic source. So we investigated 3 areas of focus, which is relationships, long-term conditions, and the cost of living crisis.
Just pause for a moment. I'm going to just test 2 things. Number 1, Pauline, are you able to advise?
Yes, I'm just going.
Yeah, okay. And then can I just have an affirmative via raising hands if colleagues that are on Zoom can actually hear discussions from the chamber? You can? All right, brilliant. Okay, fine, there you go. We've got the PowerPoint presentation on the screen, and I think we were on slide 3. Yeah?
This one?
Slide 3. So the next one. Oh, it's because I think if you just unlock the enable editing, possibly. So if you press the button that says enable editing, yeah, okay. And then go back. Yeah, yeah. All right, super. Over to you.
Right, great. So yes, this is the 3 areas of our focus of mental health in Newham. We wanted to focus on relationships, long-term conditions, and the cost of living crisis. So in our next slide, we have a snapshot of the participants' ethnic background as it reflects Newham's diversity. It's important to understand this as there's different communities that have different needs and experiences. And then to our next slide, it's, yes, our first area of focus, which is relationships. So this is just mainly a snapshot of our findings. As you can see, we got our charts and our data, as well as a quote here. So just given a bit of data, 65% of participants have reported to have a negative impact of their relationships and mental health in the past 3 years, whereas 35% had reported to have grown closer with their loved ones, which is pretty interesting. And then our next area of focus is long-term conditions. Again, similar format with the charts and quotes. So just looking at capability, 82% of our participants have reported that the long-term condition has affected their enjoyment of activities and participating in these kind of activities. You can see a quote here of a Pakistani woman who said, of a Black resident that said, "I did not know what to do or what to think. It was really stressful and putting me down." And just talking about peer-to-peer support, 71% have said that peer-to-peer support has really helped them sharing their experiences of long-term conditions and helped with them. Then moving to our third area of focus, which is the cost of living. As you know, that's really, really relevant in recent times, and one that is a strategic priority for the borough. So just focusing on sentiment, 92% had reported that the cost of living has had a negative impact on them. And finally, here's a list of our recommendations. So we hope to work with our partners in improving mental health services in our borough, helping out with the communities in our borough, and just to do a lot of engagement work. As a whole, we do believe that this pilot has shown community listening as an effective tool in gathering experiences that are seldom heard. And we do believe that it can enhance our engagement as well as improve future pieces of the work. Happy to take questions.
Okay, super. Thank you very much for that. I'm going to open up to questions. I've got Councillor Neil Wilson, and then I'll take other colleagues as I see them. Over to you, Councillor Neil Wilson.
Thanks very much, and thank you for the report. Addie and I were in a meeting only last week on a similar discussion around how people have been affected, obviously, by the pandemic, but particularly health. And I was glad to see that, you know, you've reached out to a community that I didn't mention in that discussion last week about the Somalian refugee project that, you know, posted in my part of Newham. So it's a very, that's the penultimate bullet point, that Health Watch will continue their engagement with the Somali community, gain richer insights on their access to health and social care services. And it's interesting that, just as an observation, and I'll come to the question if I may, Chair, that in terms of, you know, the statistics, I don't think there's anything that we wouldn't be surprised at. What is most interesting, though, is from my perspective, is that nearly everybody would say, whether it's Health Watch or partners in the room, that there is obviously a real sort of detrimental effect on the pandemic, and particularly on social isolation, people feeling they cannot get out enough or being even more isolated. And just to say that, have you, when you say the first point that this, we need to, as a board and other agencies, look at the available community mental health services, did you have any particular comment on a particular branch of the community health services provided by Health? Who I don't, are they on the call?
Yeah,
Paul is, because I know that Paul and I have had a recent discussion about this. So I just wondered, from their perspective, what was their engagement with, if you like, the statutory bodies before what we're coming as a for my next point. Is that all right, Chair?
So I think, so the aim of this piece of work was really to try and have local residents who reflect the local community have these deeper discussions with many users of health and social care services. Access continues to be a real concern. So for people who are, I think, at that early intervention and prevention part of being able to understand what their mental health is actually looking like. You know, people who fall below criteria or threshold. And I think there is a lack of understanding about how ill you actually need to be able to be eligible to receive statutory services. And that's not rocket science, but I think for our residents, if they're feeling unwell, we're talking therapies program, for example, just the support services, just understanding what they are, understanding how to access them, understanding that that could be a pathway to self-care and self-management. That bit isn't understood. So by the time people are needing mental health services, they're obviously very ill, and it's that journey of that continuation. I think someone's understanding. I think there's a piece of work. I think that comes out of this. How do we promote some of the low-level support that is available to effectively stop people from presenting either too early for statutory services or actually end up being on the waiting list when there could be ways of avoiding it?
Yeah, if you don't mind me adding on to this, when we did our focus group with the Somali Women's Community Group, one of them gave a really snappy quote, and they said that when it comes to statutory services, they focus on the individual, but they don't really focus on the community. And she said that we heal together as a circle. So that stood out to me, as it really shows that there is some reluctance in accessing the statutory services, as there is some kind of cultural disconnect. So I do believe that cultural understanding is really important as well. And you know, with our findings, some had reported to be turned away from the support.
Focus also on being treated as supportive as families, and of course our systems don't actually work like that, and so that's also one of the reluctances about people. There's the sense of disconnect in the way. I think that's an important point, which is not a surprise for many of us.
Okay.
Thank you.
Are there any other questions? I've got Councillor Montague.
Sorry, Mum Chair.
I wanted to find out, just looking at under the title of what do you do, and then when you talk about the figure, bottom of the page 60, in terms of measuring whether some of the users, are they coming back, or do you feel quite satisfied with the services that they've received, that it's quite content?
So that's, I think, a different bit of the work. So what this piece of work is about is actually going into communities and capturing their voices. Whereas I think there's another piece of work about actually doing some of that situations.
I guess what I'm wanting to know, do you feel those that engage with the service satisfied with received?
So I just want to note that with the questions that we've asked, they're very broad questions. So we didn't really gauge in very, very detailed answers, like, what would I say, like a humongous survey, but it was just simple questions. And then we did manage to get detail from them. When we've asked questions surrounding support, we just asked them, are you aware of the support or have you access to support? And they give us our feedback. I know when it comes to the cost of living, I know that like over 80% was aware of the cost of living support that is available, but only 80% has accessed it. And then when we've asked to those who access the support and why they were unhappy with the support that they've received, they've mentioned, like, for example, with food banks, they said that some of the food were expired or that they didn't really offer halal options, and that made them give up using food banks. One particular participant has also talked about the money support services, and she said that she did apply for the scheme. She has went to the website and filled in the application, but she hasn't heard a follow-up from them. So she lost a lot of faith in the support services that is available. Some residents has reported that they are aware, but they don't really see a need to access these services. Either it's because of shame, or either it's apathy, that they don't believe that it's going to work. So I hope that's useful. That's from what I can gather from my findings.
Yeah, is that helpful? And then I've got Paul online. Over to you, Paul.
Thank you. I just wanted to say, I mean, it would be really helpful if it's possible to perhaps touch base outside the meeting with Healthwatch colleagues about how we could follow up with some of these folk in terms of what we could do differently. Because, you know, I mean, the impacts in terms of cost of living, loneliness, relationships are obviously really widely felt. And there are thousands and thousands of people from Newham, you know, every year coming through to services. But what's also true is that there are more people where we are able to connect people with others, with communities, to work through groups, to work with faith groups and so on. So it would be really fantastic if that were possible to follow up outside, and maybe then think, well, how do we come back with some of the people who are involved, and just think for specific groups or communities, what would help, and you know, what ways would we, for example, have of putting people who are lonely in touch with other people and actually really directly coming to how we can help them.
Would be great. Yeah, happy to touch base, and we can also share our detailed report with you, which will be published tomorrow on our website.
Okay, fine. Any other questions?
Just to add to Paul's suggestion, so Julie, obviously part of the Newham Health and Care Partnership, we've got a fairly newly established mental health joint planning group, so that might be a good opportunity to bring that together and sort of get responses and start taking it forward.
Just one question from me, possibly an observation over a question, but what is uniquely different from this community listening ears model that isn't featured in other engagement models, and what is the system-wide transferable learning? And I appreciate the comments from Paul and yourself in terms of they'd be willing to engage offline about the participants that be mobilised for this. And it's within the sphere of mental health, within the context of, you know, post-COVID-19, well, it's not post, after the pandemic. But I just would have imagined all of that happens in any case, unless I'm missing something.
One of the biggest value of our community listening ears project is that, one, it's very heavily grassroots based. So it was pretty much led by our volunteers, and that our volunteers also come from very diverse backgrounds. So they're able to speak, you know, different languages that are not English, and that they could be able to speak with residents and engage with residents that don't speak English. And I could just give examples that our volunteers have spoken languages that, you know, such as Gujarati, Bengali, Lithuanian, Somalian languages. And they've really touched base with these communities, and they got richer insights from them.
Okay. All right.
I suppose it's an interesting point, and I think for me, when the volunteers came to us and said, actually, we want to get a richer insight into what residents are saying, because given that Newham population is global majority, actually how much are those nuanced voices that we hear actually fed into some of the consultation, feed into systemic change? And actually, how can we demonstrate that we've taken account of those voices? So I think a little bit is about putting a bit of structure around what that formal engagement looks like. Because everybody can talk about the spectrum of engagement and stuff like that. But what we have in Newham is the fact that we have lots and lots and lots of different communities who, if you know, we don't want to just clump people together as people from Black and minoritized communities, because actually that's a great sort of brushstroke, but actually the experiences of Bengali speakers from India compared to Bangladesh, their migration histories and the way that they engage with statutory services are different to each other. And actually, is that captured in some of the service design and service conversations that and co-designs that happen? So I think for us, it's a pilot. And I guess the reason why we brought it to Health and Wellbeing Board was precisely to hear some of the questions from members and some of the challenge, because we want to test it again with a bigger sample. And actually, I think what I think we should be able to bring back those defined voices, which is why the work with the Somali community, we want to just hear what are they saying, apart from saying that we have trouble accessing services. I don't mean that in a diminishing way, but actually, what does that mean when we say, so, the little example that Fahim shared was that we don't want to be supported as individuals, but to be part of a community, whole family, whole community approach that we want to be able to improve our mental well-being. But obviously, the part of the role of Health Watch is to just trigger some thoughts about can we do things. And it's about, if there are those things, then actually how do we test them out further? Are they scalable? Can they be replicated? And that's the bit. And we do sit on the Health Equity Board, and these are some of the conversations that we quite regularly have, both at the board and also through the diverse communities forum that is also chaired by the local voluntary community sector. So it is it's a tool of learning. I think there is we have a way to go in terms of strengthening it and improving it.
Okay, I guess it, for me, it just begs the question, and this is not meant as any disrespect, but the Health Watch has been a member of this board for as far back as I can remember, well, notably since 2018. And I can only just apologise that it's not been that systematic, well, that shared learning hasn't been institutionalised, but I was just under the assumption that things get picked up and then worked in. And one thing just for acting on, not just for, as a potential arena of mutual benefit, not least because of the work that you are undertaking and what's emerging through this pilot, we announced that we're going to be establishing a commission looking at the future of multi-ethnic and inclusive Newham that will be independently chaired by a well-known policy thinker called Sundar Kwatwala, and there'll be a separate commission and independent commissioners from a range of different sectors, both locally and nationally, but with a focus on local. And I think he and the commissioners, once they're in place, and we anticipate them to be in place sort of summer, probably June, July time. And they've got a plan for a 2-phase programme of work spanning between 16 to 18 months. They would find this level of insight really valuable in terms of the report as part of wider literature review. But actually, I know that Sundar's really, really keen to be out in the field and hearing directly and observing, and we'll make sure that those connections are made. And if that can just be captured in the minutes so that we can vote for action. That is, yeah. And I have another idea. Something relating to a commissioner possibly. But that's not my determination, but I'm more than happy to proffer you if you would be so interested and inclined. Anyway, right. Any other questions? No? Right, we're going to just move on. But before we do, I just wanted to formally, for the purposes of minuting and also good governance, can I just get agreement from colleagues of the board that we've noted as well as welcomed the report presented to us by the public team, and there are a series of actions to take forward. Yeah. Okay, great. Thank you very much. And then now moving on to the North East London Joint Board Plan, and this is going to be by Hilary Ross, Director of Strategic Development. So over to you, Hilary. Hilary, is here?
Thank you very much.
Yeah.
So I'm Hilary Ross, strategy at
Hilary, just to advise, you're breaking up quite a bit and it sounds as if either your Wi-Fi system is slightly insecure, weak, or it's outside. Do you want to perhaps try without the video? Without you being on video, that's what I mean.
Yes. Wait, is that?
No.
It's no, unfortunately. Is there a way in which perhaps you could dial into the Zoom call, and then what I might suggest is that we move on to the next agenda item and then come back to at 7 o'clock?
Yeah, sure.
Yeah.
Okay.
Great.
Try.
Okay, so colleagues, we're going to be moving on to agenda item 6, and we're going to be discussing the 50 steps 2-year progress report. And I'm going to be inviting a colleague, Adiola Agabeyi.
Close enough for Jazz.
Oh, no, I'm so sorry. How do you pronounce it?
Agbabi.
Agbeyi.
That's nearly. Yeah,
Nearly.
it'll do.
Okay, I'm sorry.
That's okay. It's a consonant cluster.
And Claire.
Yeah, Claire's online.
Okay, Claire's online. So
I'll kick off. We've got a couple of short slide packs, Pauline, which I sent to you about 10, 15 minutes ago. Fantastic. And I think Claire probably sent them as well. So the slide packs are a short snapshot and summary. We also have some colleagues to present with us, Tom Ellis from Newham University Hospital and Simon Reed from the Public Health Commissioners. So I'm just going to go through this. Item 6 and item 7 are linked, but we'll start with item 6. 50 steps to a healthier borough is the Health and Wellbeing Board strategy for the borough. It's now come to the end of its second year, and this item reflects an update on the progress in the second year. The strategy runs for 3 years, from 2019 to 2023. So we are now embarked into coming to fruition all of the things that the ideas that we had in 2019 for its third year of activity that we're looking to prepare for and thinking for the next steps for the future. So we've had some challenges, obviously. No one can have forgotten that the COVID-19 impact has a very long tail. The economic context, the cost of living crisis, given that financial security and purchasing power and the emotional stability that comes with economic stability are key to individuals and family health and well-being, that and organizational health and well-being, that's providing an impact. And NHS reorganisation, there's been as our NHS colleagues, I'm sure, will tell us, almost constant change in the national and regional structures of NHS delivery, including the introduction of integrated care systems and integrated care boards. And that has brought with it some system-wide instability and comes with change. Some of these challenges have contributed to quite clearly to some key indicators moving in the wrong direction. The two examples given here are HIV late diagnosis. So the proportion of timely diagnosis has decreased. The number of late diagnoses has increased from 29% to 35%. And this has been linked to a reduction in activity in primary care, and particularly the switch, as seen from the pandemic, from face-to-face appointments or opportunistic appointments to more planned and phone appointments. The system is responding with a commissioning of new models for delivery, different models of outreach, particularly to connect with people to prompt early connection with HIV testing, but also with an opt-out model of HIV testing in A&E. And those sorts of models are very effective in finding cases that otherwise wouldn't have been found. And then the second example of the economic climate impacting health is in the numbers of people and families in temporary accommodation. Europe has always had a high number of people in temporary accommodation, but that's increased by 3%. And the market, the cost of living crisis, rent increases, and the overall shortage of affordable homes and changes in benefits, pressure on benefits has created this negative change. So the council is addressing this through cross-council homelessness response programme and the building of affordable homes. And I'll come to bring in Simon Reid to think about some of the challenges and successes around housing in a moment. This next slide, please. Next slide just shows 4 key areas where we're really proud of our activity over the second year of the strategy. That we have, and it's really always good to hear Health Watch as well, but we have a real focus on community involvement, community activation, community engagement. We've engaged with and involved over 1,500 residents in developing the Ageing Well strategy. We have, from COVID-19, enrolled over 500 COVID-19 health champions who are now becoming community health champions across a range of topics. And the domestic abuse strategy was developed and implemented with domestic abuse survivors and residents. And the theme of involvement is continuing through and will be seen in the year 3 update with more activity around the launch of Wellbeing and the co-design of Wellbeing. We have partnerships. We have really strong partnerships. Some were forged in the heat of battle in COVID, but those partnerships continue across the health and care landscape in the borough. The Creating Healthy Schools, from 5 schools were awarded, had awards in 2021, 53 schools in 2022. The Newham Food Alliance, which contributes to food security in the borough, 42 partners have delivered 500,000 parcels since starting in 2020. The Vitamin D programme, again, a community-based programme in which places of worship and community sites offer to give out free vitamin D bottles to over 65s. They have distributed over 28,000 bottles over the past 18 months, made a tangible health benefit to several thousand residents, many of whom weren't aware that vitamin D was an issue for them and worth them having. The Anti-Poverty Alliance, 50 partners are helping to respond to the rising cost of living. In a policy context, we have a policy of embedding health in all policies, which is step 1 of the 50 steps. We have a policy of health in transport. We're supporting active travel. We partnered with Transport for London on giving free food away as pilots at various DLR and TfL stations. We have a health in housing policy, looking towards energy efficient homes and energy efficiency enforcement. Health in planning policy, we have proposed health impact assessments that we're working on the planning department with, and the Ageing Well was shortlisted for an LGC Public Health Award, really following on the footsteps of the whole strategy, which won the MJ Award last year. And finally, for impact, polio, we supported the NHS and primary care, again, as with COVID, but to give over 17,000 vaccines in a very tight timeframe for a polio campaign over the summer in response to findings of polio sampling in sewage water. The universal primary school meals campaigning that has started in Newham has influenced London policy. And we continue to be a beacon in that area. We're welcoming hundreds of people seeking asylum and refugees into the borough. Newham is always was and always has been a portal of entry into the UK. People will continue to come. We are ensuring that when they do, they get the appropriate welcome and the appropriate information and socialisation to be able to help them land safely and well. And the number of people sleeping rough has fallen from 68 to 13. Next slide, please. For the focus for a year ahead, we have 3 broad areas of activity: building a fairer Newham, completing on the promise of the 50 steps for year 3, and continuing to develop place-based partnerships. So building our success, delivering on our commitments, and addressing areas for further action. And this is just a collection of some of the examples of the things we'll be working on. Look out in June for the launch of Well Newham, and also as part of partnerships following hot on the heels of that, work with the NHS around promoting new diabetes remission pathway. We are in the process of launching the Centre for Health and Care Equity, which will, I'm sure, be a worthy partner to the Commission on a multi-ethnic Newham, looking to capture practice, good practice and learning, and share learning on what works to make sure that our services are both health promoting and equitable and fair, looking to achieve and continue to Borough of Sanctuary status, to continue in the food arena on food growing initiatives around gardens in 14 schools that also act as sustainable drainage systems. Connected to Well Newham, working to partner and co-locate with pilot family hubs. It's a DFE initiative, and we're doing some work across the council to make sure that there's synergy and connection between the hub initiatives, particularly where they have overlapping populations and overlapping issues. And ways of working. Looking to scale up Healthy Start, faith settings, food banks and other locations, again, building on the strength and success of the vitamin D rollout. Looking to get to grips with and commission a new leisure offer, and looking also, and particularly important in this economic climate, to deliver on the first year of the suicide prevention strategy, which will be a whole borough-wide campaign-based approach, which is a multi-partnership approach also. Looking at oral health, again, building on previous successes with Healthy School Streets, and again, looking at implementing a new model around supported living. And I'll go to stop there rather than reading out all the boxes. You can read them all yourself. But I'd just like to ask Simon Reid if he'd like to join us just to add a little more detail to some of the work that's been happening, particularly with the Public Health Commissioners in partnership, around supported living, around rough sleeping, and also thinking about the exciting Healthy Lives commissioning that's supporting the Well Newham launch around some of the weight management services that are coming to the borough now. Simon?
Thanks, Addy. I think when you start on a journey like 50 Steps, you start with like a lot of hope and aspiration. You look at the evidence about what works, but we have a very diverse borough. So there's also a bit of crossing your fingers and hoping that you've got the right plan. So looking back on this now, you get to kind of test out whether things works well or not. So we can look at rough sleeping, and those numbers are slightly better than they were. I think 5 years ago, we had about 200 people roughly sleeping in the mall. That's down to 5 now. And that's not just a huge amount of work, but that's approaching it in the right way with care and compassion, and really trying to address the wider determinants that led to those people sleeping rough in the first place. That work's been recognised nationally by the Secretary of State as kind of a leading kind of model in the country. Just touching on smoking quickly, we didn't have much of an approach prior to 50 Steps. The previous administration didn't prioritise that as a public health area. Since we've been mobilising the new service model in 2021, we've had 900 people quit for 4 weeks, which is the national benchmark. Only last week, we were recognised again nationally and by ASH as a leading system in the country, and one others can learn from. And that's a dramatic improvement really over the last few years. And then finally, in terms of weight management, we have a huge obesity and overweight issue and diabetes as a result. Again, since mobilising our offer in 2021, we've had around 500 people lose a statistically significant amount of weight. And again, that's not a one-size-fits-all approach. That's really about kind of listening to our communities, working with them and developing things from the ground up. So I'm really pleased that the stuff we hoped has managed to come to pass, and very much look forward to next year and the next round of strategies to go ever further.
Thank you, Simon. I'm going to ask Tom Ellis from Newham, the Director of Strategy for Newham University Hospital, to also give a short update on how the hospital and Barts Trust have been working with the public health team to look at embedding the 50 steps across strategy and action.
Thank you, Addy. I've got a lot of reverb.
Oh, ow.
Is that? I don't know why that's happening.
Two devices.
Yeah, Tom, we've got an issue with feedback.
Shall I leave and come back?
Yeah, just wondering, is there someone that's got their? Do you want to just say something again, Tom, so we can figure out?
Is that any better? No.
No. Is there someone in your room that's got their computer on and watching you, or?
No.
If you turn the sound down on your speakers, that might do it.
Yeah.
So leave the mic up, but turn the speaker sound down. So.
Okay. Oh, that sounds better.
Yeah, that definitely sounds
Okay.
better.
Sorry about that. I think that was my mistake. So I think the thing is, from my perspective, this is sort of part of the place-based partnership, and it's about making the place-based partnership more than rhetoric. And I accept that last year and this year, a lot of it is around governance systems, and plans getting developed. But we believe that Newham Hospital has a role to actively actively addressing partners deliver their own agendas. I've said in meetings before, but it's about, in a way, your problem is our problem, and by the same token, our problem needs to be your problem. I think it's about organisations in Newham being much more collegiate in their work. And although we've been, I think, in an ad hoc way, supporting elements of 50 steps, what we've tried to do over the last 6 months or so is to much more formalise the process around support. So we actively reviewed the programme of 50 steps, and we believe that in 39 of them, we have a role to play either directly or indirectly in helping or in some areas, helping evidence delivery or helping provide evidence of delivery of that step. And some of it is making sure that activity that's already going on at the hospital is being communicated through to the relevant person in LBN who holds that particular portfolio. And we know in some areas there is good communication flow, but we're not convinced that that's the case across the board. So we will be working to try and understand where and how we can impact on the 39 steps that we think we have a role to play in, and we've been working with Claire on that and Addy on that. And also we more specifically, and I think this is about, again, place being more than rhetoric, we've actively said to LBN, of the 39 steps that we think we have a role to play in, which are the 3 or 4 which are priorities for you that you want us to really focus on. And we've got those 4 back from the borough. We are going to build them into our own hospital plan as 4 key deliverables for the hospital in 23-24. And given that the total hospital plan has circa 90 deliverables, 4 of them are directly linked to LBN 50 steps. And we will monitor delivery against those 4 priorities through the course of the year and report on them as we would any other priority for this hospital over this year. So we think it's important in principle and also in practice. And I think we also, as a hospital, we will use this year as a test of how we include place-based targets in our own plans for the coming year. Final point, we'll be taking the plan, is going to group exec this Friday. It's going to our hospital exec board in May just to ratify. And then we'll be looking to work to deliver those, but also work more closely to understand where and how we can provide evidence around other steps where Newham Hospital is taking action that helps delivery of that particular step. Happy to take any questions.
Okay, so I'm going to open up to questions and I'm going to check if there are hands up on the screen. Any colleagues that want to kick off? It's either a sign that everyone's so familiar with they all know it. Over to you.
I less of a question, more sort of feedback that I thought the review was really positive. It really sort of cements what's been achieved, particularly the sort of KPIs and the overarching progress, and also the areas that we could sort of work collectively to keep going on. So I found it really helpful. I think it's really good for us to sort of take forward together, and probably added more of the sort of NHS ICB sort of what's coming there, and the sort of next item we've got as well, how we strengthen that link up more as well.
Thank you, Marie.
Yeah, okay. And then I'm going to be inviting Councillor Neil Wilson.
Yeah, it's more a question across, as it were, to primary care, because there's a reference on 268, which I welcome, as about the safe surgeries. I mean, as Addy rightly highlighted, Newham has throughout its history, but before East Ham and West Ham, all of East London has been a receiving area. We're under increasing pressures on various issues around people to be supported who are refugees, people seeking asylum, people with unsettled status. There's a reference on page 268 about the safe surgeries through partnership working. And, you know, the whole idea of doctors of the world is that, you know, we're a global society, and Newham is a microcosm of the global system, as it were, with its great diversity we've already talked about, and the Newham training hub. And it's become the first local authority area where every GP is signed up to be a safe surgery is something that I think we shouldn't overlook. And there's so much good in this that we might say, oh, well, it's 50 steps. I mean, it has been criticised in other arenas here that 50 steps was a scattergun approach. And I've refuted that from the start, because there is so many issues affecting our community that, you know, we need GPs doing just on that one example. Anyway, the comment was to primary care colleagues about, because I know we're going on to another item because it's difficult. We're, you know, on this 2-year review, in terms of, I'll just use that as an example, that the 50 steps, has it been, because we've had the reorganisation around this as well, where primary care is sort of away from what we might want it to be at the moment. So I didn't know whether, if I could ask a question across on that one.
Okay, to answer or respond to that first.
Yep. I think, thank you very much for the kind words. And yes, a great deal of work went in through colleagues to support surgeries to sign up for that. But there was also a great deal of willingness from surgeries to do that, and that we have continued to develop around that refugee and migrant health work stream. We now have a much more fully fleshed out refugee and migrant health work stream as part of the 50 steps. Primary care has been under challenge since the pandemic, and like the rest of the NHS has challenges with funding, but also challenges with the high levels of need. We are continuing we have great, and those in the room, partnerships with primary care, and are looking to develop and support and strengthen those as well. So just because we haven't mentioned by name up to now doesn't mean that they're not there and fully fully growing and thriving and moving. But yes, primary care has a challenge, but I'll stop speaking about it. And if Wax wanted to say anything, but he might not.
I mean, absolutely. I mean, what you hear in lectures and shop, it's great to see the achievement around the safe work. It's great to see the achievement around the safe surgeries work and to be one of the first boroughs in London to be recognised as safe surgeries. And I hope everybody knows what safe surgeries means. It's the ability for residents to be able to register without kind of being uncomfortable questions around what the postcode is, etc. Being registered in pretty quick time. And that is ever so important in a borough that's population is under so much flux. So we know parts of the borough that the GP lists change over around 40% in campus, those about 10%. And especially looking forward, we absolutely need to make sure. So in a year's time, when we do it at the review, I want to make sure we've absolutely closed that gap between the numbers of residents who are in Newham and how many of those are GP registered as well, because we know that that's population that the coming years. So that's on it's the fact that patients are registered and have the ability to access good quality. But like I said, that's a snapshot, and we're doing a lot of work around access in partnership with colleagues. And we look forward to presenting, in addition to the work that's in the 57, which is a refreshed primary care strategy for Newham in the coming sort of months as well, which will really go heavy on access, new models of care, quality improvement, and workload. Making primary care in Newham fit for that growing population that we expect to see in the coming months and years.
Okay.
Thank you, Chair. Yeah, I was just going to make a comment. I think, again, reflecting other comments, I think it's a really positive piece of work. And I think what we're starting to see is greater alignment and coherence across different sort of strategies and initiatives, particularly thinking about Newham and the Family Hubs work. That real focus on a more integrated, locality-focused preventative approach to supporting residents. And I guess just the other reflection is not just what we're delivering, but it's the how we do it. And it's the way in which we work across agencies, and certainly through Babies, Children and Young People's working group. We're very much thinking about how do we work together in a more integrated way, and how does that enable us to transform the way we deliver services to residents. So just feedback there on how I think things are gaining greater alignment now.
Thank you.
Over to you.
Yeah, I'm just going to say, as a complete piece of work, and remember this from when we attended the MJs, that one thing that's struck 50 steps is that, yes, we've got evidence in areas around success on KPIs. But a lot of the measures here are evidence-based. So the fact that someone has attended for an appointment for a foot check, that's an evidence-based intervention. The numbers are super important, outcomes are super important, but these are a set of evidence-based, because I know a lot of everybody talks about outcomes. List of outcomes, and we've improved from this year to this year to this year. But the fact that we've introduced a number of evidence-based interventions is.
If I may, can I just pick up on that point you've made around evidence-based outcomes? Sort of just reading across the progress highlights and then moving on to summary of KPIs. In all sense and purposes, they feel more like inputs over outcomes, albeit some negligible outcomes. And obviously, there's only so much we can glean over a short defined period of time so far in order to make any grand claims that we're shifting the dial, just given the scale of health inequity that exists and shortens life. So what's the time horizon for us to credibly state, actually, we are beginning to shift the dial, or we have shifted the dial? So I think often about, you know, the intentions since 2018 around childhood obesity, but that doesn't necessarily correlate to people in adult life dying younger because of heart disease, because obesity and heart disease don't necessarily correlate. So is there, as part of the 50 steps version 2 or 3 or whatever it is for the next cycle, is there needing to be a much more nuanced and granular thinking around outcomes, appreciating the shift in the dial also requires some pretty radical system change, given the social determinants of a lot of these things. But are we looking about a generation? So a young kid at 1 month at the start of this programme, when they get to 18 and we're doing a health check, it'd be like, wow. Anyone? Yeah.
And I think that Claire might have something to say about that as well. I think that, so the time horizon for public health is in tens of years, and that we're talking about things across the life course, and we can look at outcomes, but we need to have outputs and interventions and systems and ways of working in place in order to deliver them. We are also, with the wider and commercial determinants of health, up against some pretty big challenges. And part of the way that we'll be working, or we are working, is looking at the system changes and ways of working, as Tim says, not just the what, but the how. So I think that this represents the progress of getting the systems, processes and partnerships into place, which are a necessary foundation for beginning to be able to start to shift the dial a little more reliably. And yes, I think we've picked the type of succession progress measures that make sense to the type of activity that we're doing, the outcomes that we want to see in the long run. We can put them there as targets, but they're not some things that we're going to be able to achieve, for some of them, around, say, the translation between childhood obesity to a healthy, free life expectancy over the next 30 years. They're not something we're going to be able to measure easily, but we can look for the right sort of questions that will track the journey. And also will track and bake in those equity and fairness asks as we go to make sure that we are creating opportunities, or we are addressing the inequalities that are quite strongly baked. And I can see Claire's hand.
Claire.
Thank you. Just to add to what Addy said, and we're going to come to that in the item around the refresh of the strategy. We are intending to put in there some more specific outcomes that we want to be able to look at and then to track year on year. And we need to be really clear in that we're not necessarily expecting those outcomes to change in a year or even in 2 or 3 years. But we definitely want in the new strategy to have some outcomes in there that we can at least report to show what are the high level outcomes that we are looking at as a system, that we want to be able to report and that are really important for us to know about and to track.
Councillor Wilson.
Yeah, sorry, just while we're on KPIs, I mean, one of the things that I've been tweeting about, and so is the council website, I think, is about MMR coverage, because, it's World Immunisation Week. I note that even on page 229, despite our very best endeavours, it's the MMR coverage in children by 2 years hasn't changed really from 81.1. It's sort of up in, by 0.3%, and the MMR coverage in 5 years. I mean, Addy referred to external factors. I mean, just as another segue under children's health about the oral health brush kits, but in other areas, scrutiny and elsewhere, as you know, the dental service provision within Newham has been, and Healthwatch have been working on this with us. So it's about how with this report, the KPIs that we've got, given all the caveats that, you know, the chair mentioned and yourself, Addy, is that I think there's, whenever we do a report like this, which is a sort of summary, it's not a snapshot, it's a load of work there, but the external factors are not used as an excuses, but they are something that we have to still deal with it as a multi sort of factor approach to this. Yeah? Would you agree that the MMR one is quite a good example of how, you know, there's some negative publicity, there's some fears, there's some work that we've had to do, just like we did over vaccination for COVID-19.
Yeah, if I may, Chair, yes, I would agree that there are challenges, but they're not excuses to not look to address them and mitigate them. On the topic of childhood immunisations, that I got some good news by email earlier today that for the 21-22 QOF data, of all of 273 practices in the whole of North East London, only 10 got all their childhood immunisation QOF points, so their kind of success targets points, and 6 of those 10 were in Newham. So that despite the challenges for primary care, there are primary care colleagues in Newham who are turning out day in, day out an excellent shift of work. They're doing really good things. And there are also primary care colleagues, particularly looking at Karen on screen, NHC and the NHC roving team and their ambitions, that working closely with public health around primary care network inequality strategies, which also include dental health, but also thinking about ways to support all of the practices to be able to learn from those areas of excellence and also learn from the areas of challenge, to be able to share that learning across the system, to be able to help everyone achieve their targets, even when we know it can be quite difficult. So yes, there are challenges like things like the MMR and immunisation and the noise around certain parts of the system can be challenges. But I'm confident that we are creating the strategic framework and partnership framework to move forward and start to address them.
Sorry, we were a bit distracted.
Yes, there's just a snooze button. We're just going to get that sorted, but
thanks. I think it's absolutely.
It's going to be cancelled, and we can snooze and be reminded in 2 hours. If there's a 4-hour option as well.
You want to stay?
Okay. Brilliant. Right, Chair. It's okay. Let's carry on. And I will wrap up because I'm now running 10 minutes over.
To add to the IMS part. I mean, great. I mean, look at the coverage. So Ade's articulated at a high level that, you know, have a plan in place. Different areas. This, you know, as you put my GP hat on, put my practice hat on, the reason why we didn't get 100% was not because anything didn't have in place. It's just the goalposts are impossible to achieve. So we have 4% of our residents for that specific target were vaccinated outside of the UK immunisation schedule. So they were vaccinated abroad
Already, yeah.
That doesn't count. Because that's not, so we know in the subcontinent, for example, that vaccination is done at different intervals, and those intervals do not align with what we do here in England. And I would have expected to see the top 10 practices in North East London all be from if it wasn't for that's and all of that's been fed back to NHS England. So sometimes things are just not, and actually the picture is better than what is presented here. So we'll carry on working on that as well. I must say that working in partnership with colleagues, we're really talking about it, and that's not from the MMR. That's around the polio, being the borough that's getting more polio booster vaccination than the other borough of London. and now sort of entering into phase 2 of that programme. And the MMR is actually one of the IMS that's much more harder to get than, for example, the DTP, as it were, or some of the other immunisations, the 19 immunisation programmes we're delivering here. So yeah, well done to all of them.
Yeah.
Yep.
Okay, we could go on, no doubt,
Yeah,
but we better not. Okay, we're going to pause and then we're going to jump back to the North East London Joint Forward Plan. And if I can invite our colleague back, I'm sorry, I'm just going to the page number, which is big page number 21 in the agenda pack. Hilary, back with us.
Oh, yes. Is that any better?
Oh, that's amazing. Thank you.
Fantastic. I have ditched the trying to come in through the NHS system and gone through a different device. So I'm really apologise for the disruption earlier. Thank you. I'm Hilary Ross. I'm Director of Strategy for NHS North East London. I know we're a bit behind time, so I'll try and be as brief as possible. Previously, I came to your previous meeting to talk about the development of the Integrated Care Partnership Strategy. This is about the Joint Forward Plan, which Integrated Care Boards were asked to develop draft versions of by the end of March this year, with final versions due to be submitted to NHS England in June. I am also conscious that many of you, as other health and wellbeing boards are telling me, have had quite a bit of discussion about the Joint Forward Plan already in a number of other meetings. So I don't want to go over it in detail, but what I was hoping to do was just give you a sort of sense of where we've got to with this piece of work now, and to ask for your feedback on our current draft. So just as a reminder, this is the draft system delivery plan. It sets out our key drivers for change around poverty and deprivation and population growth and all of those sort of key challenges, the assets that we can draw on, including our richly diverse communities across North East London, our workforce across all different sectors. And then it starts to set out how we're going to deliver on current pressures, our range of commitments as an ICS, as well as the local priorities that we have set out with you in our integrated care strategy. We are aiming for the Joint Forward Plan to be a live document, which will continue to develop further, both for the deadline in June, but also over the summer to feed into the next business planning cycle. And the areas that we are currently developing further with partners include our workforce strategy, and we had a workshop with many different system partners gathered together just on Monday this week to support developing that work. Other strategic work around digital, around primary care developments, further development of our overall operating model for the ICS to really understand in detail with partners how different parts of the system is going to work together to deliver the outcomes and address inequalities, and working together more as a learning system. And then we also want to do, what you've got is a very, very detailed pack with a lot of information about the range of different transformation programs happening across our system. And what we want to do is further sort of check and challenge with stakeholders over the summer to look at that transformation work, ensure it's aligned to the population health needs, which we set out, and the priorities in our new partnership strategy around prevention, co-production, and so on. And there's also, as colleagues were just talking about, further work that we need to do at the system level as well around the development of outcome measures so that we can really monitor our impact on population health. So we're really keen to hear from you at this stage about where we've got to, particularly around how you feel this current draft aligns with your local priorities here, but also any gaps or areas that you think we need to strengthen as we continue to work on this. And I'll stop there. Thank you.
Okay, great. Thank you very much, Hilary. I'm going to open up to colleagues to be asking questions on the back of what they've heard, or any comments. I can't see any virtual hands up on the Zoom. Is there anyone here? I've got Wax, Doctor.
Thanks, Hilary. I mean, I know you've done immense work on this. It's totally 200 pages. I've almost managed to get through most of it. I think collectively we're about managed. And on every page I see, every other page I see the word inequalities. And you know, we've learned much about inequalities over the period of pandemic and coming out of the pandemic. It's such a priority, and I just wanted to understand where have we got to in terms of kind of baselining our resource, not only in people, but also financially in being able to address those inequalities. Yes, we have a core kind of funding situation where we spend on primary care or acute X and Y. Where do we have a sort of commitment to an inequalities widget, as it were? I would say a wedge, and also have we had any commitment from NHS England around resourcing some of that work? Because in all of our forums we are talking about inequality. We absolutely know that we need to tackle those. This forward plan talks a lot about that. Speaking to colleagues, working with colleagues, we believe that will take people and resource, financial resource, significant financial resource, and you know, it'd be, I think, important for the Health and Wellbeing Board to understand what commitment has been given towards addressing those two things. So that capacity in terms of people, but also funding in baselining action on inequalities in our kind of core spend.
Okay. A really important point, Hilary, but I'm not going to ask you to respond yet because I want to take Rima first, and then I've got Colin Ansell, Interim Chief Executive, Newham Council, and I'd like to come and say my piece as well, because basically the board theme no doubt will be we need the money and what you're going to do about it. And it's really interesting reading a nice chunky wordy report, but can you please put your money where your mouth is? I think I'm probably being much more diplomatic than anyone else. Okay, Rima.
Thanks, Mayor Fires. So I guess, Hilary, my question is, this strategy is kind of a very high level strategy, and I would expect it to be in terms of at that sort of NEL structure when you look at the whole landscape across North East London. And I'd say that most of the priorities do align to what we have in Newham, but I guess next steps, how do we make sure that there's that connection with the local delivery? Because I'm still struggling to see how are we actually going to use this strategy and actually make some meaningful outcomes at ground level. You know, what does that then look like for our population? So I'm just sort of, it's kind of, I guess, more the next steps from this, and how do we make sure that that relationship with the local partnership and health and wellbeing boards is much stronger than it is at the moment?
Okay, and then Colin.
Thank you, Chair. In a similar vein, really, I think that there's the connection to the place, which is really important. Actually, how maybe just my view on this as a document is, yes, it's really important at a NEL level what's going on across the piece, but at Health and Wellbeing Board in Newham, I'm really interested in that what's happening at a NEL level links to Newham, doesn't necessarily link to all the other areas as well. We can, you know, so I think it's about for elevating the what difference is it going to make to Newham, which I think is really, really important. And of course, our local priorities, and I know you have to dig a little bit into this report to get to our stuff, but also how our priorities are influencing back the other way. So I think it's not just a one-way street in terms of those priorities. And of course, any money is graciously received to pick it up on both Mrs. Point and the chairs.
Okay, I'm going to get to Councillor Neil Wilson.
Totally agree with the resources point, the population growth inequality point, and the Newham focus point, which is place. You know, there's some references in there, but just in terms of on big page. Sorry, it's sort of it's in type. 101, I think, but anyway, where it's core elements of high quality care. I mean, I've had some into the document in terms of, as you know, the strategy, but in where we've got enhanced health and care home, just a response to the already complicated landscape. It's just an observation that, you know, it's by April 2026, which was like how many years ago, 253 care homes providers. That's just the providers, let alone the actual locations of those across the North East London footprint, with a very diverse quality and CQC frameworks coming in quite soon to be even more, hopefully, rigorous in some of that quality provision. But all care home providers were working workforce learning together, significant 7 training across all NEL boroughs and digital platforms. It's my understanding and hope, as well as desire really, that we have learning across on an integrated care and health system, so that we don't keep repeating the mistakes. And the one thing, the sort of elephant in the room behind all of this, is we've got a workforce strategy, but we actually have a real issue with the current workforce in care homes and the inability of central government to actually reform in a decent way and resource provision. So I think there's quite, I think we just need to keep flagging up every sort of possible opportunity, a health and wellbeing board, that, the Newham residents in those care homes, with a fragmented relationship with us in terms of whether it's primary care, whether it's the hospital, whether it's with even the new landscape. That's sort of like, you're nodding, but I think we just have to keep sort of putting those messages back. And I think taking up a question that I think Wax said, is it when you were talking about the national landscape, do we have separate from this? Because we alluded to it at the integrated care partnership about the campaigning and how health boards. Is there a point where health and wellbeing boards across the piece also join in that campaigning thing about resources and allocations and the top-down sort of NHS edict? Because there's already been cuts announced since they asked us to do an ICS and ICP. Sorry, a long question in one, but thanks, Chair.
Okay. Yeah. Right, Ade.
Thank you, Chair. So, as echoing things that have been said before, thank you very much for presenting this, Hilary. And there are plenty to look, read, and get one's teeth into. And there are some very helpful snapshots and data depictions. My question is, it's echoing Colin a little in that this is it's a two-way conversation. I really value what you say about the learning nature of the strategy and the need for setting up effectively learning communities to develop this way of thinking or to develop your strategy. There are a number of notes in here about particularly thinking about doing things differently, that the current models of healthcare delivery are unsustainable in the current climate and unsustainable with the demographic changes. And you highlight, the report highlights adult social care and places, public health, and the voluntary community and faith sector as areas for exploration and discovery. So I definitely welcome activity and thinking and learning in those spaces. And I'm interested to hear more about the VSE collaborative, not just valuing the VSE more, but actively demonstrating that value by working on co-design and co-production on some of their areas of expertise, which are definitely more than some of the areas that they're currently featured in around translation and advocacy. But it's certainly a space to to think about bridging gaps between services and residents, particularly since the other direction of travel, apart from population growth, is technological growth. And while there is inevitably a move towards digital and a move towards new pharmaceuticals, some of those really challenging drivers of poor health are not necessarily going to be immediately fixed by new medication. For example, we're not going to fix childhood obesity by a new injection yet.
Okay, let's just get a response in the round across all of those points, questions.
I'll give it a go. And I think just to say that the purpose of this discussion with you today is not necessarily for me to come with all of the answers, but to hear from you where you think we need to do further work and where you really want to see that sort of greater synergy with local priorities and etc. But just a few points, and it may well be that Marie wants to come in, particularly around how the sort of local place resource and structure is developing, because we are currently sort of holding a consultation process for staff in the ICB, and as part of that have got proposals around what place teams that we're going to invest in future will look like. So I'll leave that to Marie to pick up if helpful. But there is some good news about health inequalities funding, specifically for health inequalities. As I'm sure you're aware, in last financial year we had a national allocation to spend on health inequalities, and we have just got agreement that we are going to invest in health inequalities to the same measure over the next 3 years, with the majority of that funding going again as last year to place-based partnerships, to really support that local action, that local partnership working and collaboration to tackle health inequalities. I think that whilst that's really important, there is a very valid point about, yes, but that's 6.6 million. What about the other sort of almost 4 billion that is spent in the local health and care economy across North East London, and what are we doing and how are we using that money to address inequality and improve outcomes for local people as well. And so, but very much in the strategy that we produced, which we're now trying to reinforce through this joint forward plan, is that focus throughout all of our work on addressing variation and inequalities. I mean, those issues that people are talking about the kind of place priorities and needs, and how that links to the system, are the things that we are still grappling with. I mean, obviously each place across North East London is developing a place-based partnership alongside its health and wellbeing board, and there's been work in other places about what that relationship might look like, and in some places there's a sort of more formal relationship developing, and we're keen to sort of explore those sorts of issues with you further, and that piece of work I mentioned earlier about the kind of developing further the operating model, about what each part of the system is responsible for, and how all of that becomes mutually sort of reinforcing is work that we want to continue to do. I think I think it is really helpful if that we start to have a sort of common script about what some of the key drivers for change are across North East London, so that we can have a kind of, where we do have a platform for talking to the region or nationally, there's a really sort of clear shared narrative about our issues here in North East London, right across all of our places around poverty and deprivation, and the population growth and the investment that we need in our clinical and care capacity, as well as our infrastructure, to deliver on the needs of our population as it grows and as those needs become more complex over time. So I think that's something we're keen to sort of really help develop. in terms of the voluntary and community sector, we've got a really good developing relationship across North East London, the development of the collaborative, which we can share more information about if helpful. Just one example, in Newham, we've just been doing a piece of work. We had some funding to do a piece of work looking at how we develop a research engagement network across North East London, and we piloted a piece of work that we've done in partnership with the community voluntary sector in Newham and in Barking and Dagenham, and we've just had the most fantastic set of conversations with the community about how to engage people more locally in research. And that was only possible through working in partnership with the community and voluntary sector locally. We wouldn't be reaching the sorts of, the local people as we have done without that partnership. And we know from all of the engagement that we've done with the VCS that it's not just about bits of project funding, it's about a much more sustainable funding model that enables that capability building, capacity building over time, and that's something we're really committed to supporting as well. But thank you as always for all of your thoughts and for being so candid with your feedback as well. We'll look forward to sort of coming back to you in due course with further iterations of this plan.
Thank you very much. I am going to make more comments and move on to considering the recommendations. Okay, just noting sort of the summary sections and also noting the fact that this is the first 5-year plan, and drawing on the social determinants of ill health. So what I think this is probably a question just for the Health and Wellbeing Board and the local system made up of partners, is to what degree can a North East London joint forward plan credibly respond to local need when there are multiple local authorities and partner systems that cover quite a wide geography? And are we going to have to be in this perpetual state of negotiating and mediating our local needs over the North East London geography, desire to arrive at a finessed forward plan so that they can tick a variety of boxes, but not really do anything substantial and shifting the dial in terms of local health inequality features, and I suspect so as a board not going to really cut much mustard. Okay, right, so recommendations. It is recommended that the board, 1, consider and comment on the NEL JFP and how it aligns with the Newham's local priorities, and identifying any potential gaps. I think we've given some top lines, but I'm assuming that there's proper, rigorous, detailed SA feedback that has been submitted or will be submitted from Newham and then different.
We're going to say Colin first instance and
So from your introductory remarks, Hilary, you said that this will be returning back after consultation during the summer. Is that correct?
So this is a first draft at the moment. We are going to be submitting a sort of a next draft, taking on board comments from Health and Wellbeing Boards, place-based partnerships and others in June, according to the national NHS England timelines. But really, this is a live document. What we're really keen that actually a more important deadline for us is the sort of September time, when we will be starting our sort of business planning cycle for next year, wanting to influence the annual operating planning process and all of those sorts of things. So I think it's not suggesting we get to a point where everyone goes, yes, we're happy with this, let's put it on the shelf and do this. I think it will continue to iterate as we work together on some of these issues, but we are keen to capture thoughts now about where we are today.
Okay. Yeah, go on.
So you've received today feedback from the Health and Wellbeing Board in terms of the initial thoughts. I also wonder if the recommendation should be expanded to say that actually colleagues from the Health and Wellbeing Board will consider the plan and feedback independently to yourself, Hilary, but also that we will consider it at the place-based partnership also, and maybe that could be a feature of future reports where actually we join the two together from a board view as well, so that actually starts to make those linkages.
Okay, so I need to borrow someone's pen.
I'm so sorry.
It's all right. May I borrow your pen just for a moment? Thank you.
Is it?
Okay, so
What I said now.
what was the second part? Outside of submitting?
That there is also a discussion at the place-based partnership in relation to the plan. I know we've had some, and actually when this comes back, that there is a view from the place-based partnership on the synergy between those plans. So
yeah.
I think that's what I said. What's about it?
And just Chair, just to add, so we are going to all of the place-based partnerships as well. Because of the timelines we've had to work to this year, it's not been necessarily, we've not necessarily been able to do everything in sequence, but certainly that discussion is happening, and ideally in future years we'd be able to sort of schedule things so that there's so that you get a view from your place-based partnership as well when we have these discussions.
Okay, so what I've got as potential amended recommendations. So book page number 22, 3.1, it is recommended that the board 3.1.1 consider and comment on the North East London going forward plan and how it aligns with Newham's local priorities. 3.12, identify any potential gaps and for each Newham Health and Wellbeing Board partner to submit comments to the plan. And then 3.1.3, agree that future iterations of the North East London Board plan, joint board plan, is additionally referred to the place-based partnership for discussion and alignment.
Yeah.
Yeah?
Yep.
Get that?
For discussion and alignment.
Yeah. Okay. Right, so, and apologies if I've missed anyone else from the Zoom platform. So in light of the amended recommendations as stated, is everyone agreement? And I will take particularly weighted the people in the room. Is that agreed?
Agreed.
That's agreed. Okay. Thank you very much. Now I'm going to be jumping to agenda item 7, which is 50 steps even 2.0.
Hi, everybody. For those I haven't met, I'm Claire Greshak, one of the Deputy Directors of Public Health, jointly with Adiola, who's in the room, and I'm going to present this item. Brilliant, thanks, Pauline. So we're bringing this item to the board today to present some of our early thinking about refreshing the 50-step strategy. So really here to present some early ideas and to get everybody's thoughts. So a few points to start with. The 50 Steps has just started its third and final year, and so we're starting to work towards thinking about what happens after that and how are we going to refresh the 50 Steps to build on all of the really good work that's happened already and address some of the gaps or the things that we haven't progressed in the way that we would have wanted to. So it also represents a really good opportunity for us to contribute to the council's vision for health, happiness and equity, and to align with the council's framework around that. It means that we'll be building on our progress and our success and our learning that we've talked about earlier in the earlier item. And it means that we can reflect and align with the new context. So since the first iteration of the strategy was developed, we have a new corporate plan, Building a Fairer Newham. The NHS has reorganised, so we have new NHS landscape and new priorities, as we've just discussed. And there's a lot of emerging really key strategies in Newham and key priorities that we can make sure the new 50 Steps strategy aligns with. So, for example, big priorities around climate and around inclusive economy and equity and a whole range of other things that are really key for health and well-being. So in developing a refreshed strategy, we can make sure it clearly links and aligns and supports those wider strategic aims. So if we just go on to the next slide, please. There's our high-level thinking is around what are the kinds of actions we might take in the next iteration of the strategy. And the first strategy has 50 steps, and all of those steps are to varying degrees of specificity about making incremental improvements to the way that we deliver services and the way that we organise ourselves to improve health and address health inequalities. For the new strategy, we've got a concept of, broadly speaking, 2 categories of action. So one category is what we're calling incremental improvement. So that's continuing to build and improve on all of the things that we're doing, all of the things that we've done as a system over the last 3 years, and the things that we want to continue doing day in, day out to just continue to improve on. The box on the left is what we're calling game changers. And this is a concept of bigger commitments that as a system we can take, that if we commit the resources or the partnerships that would be required to deliver them, we could really deliver meaningful change at scale in Newham. But it would need that commitment. So that might be a commitment of investment or major policy change or a new partnership way of working that we're not doing. So these are really thinking about a small set of big ideas that if we can deliver them, the evidence suggests they can make meaningful change to health and well-being. And on the left, there are some examples, but what we're going to be doing, and I'll talk to it in a moment, is to be working up a long list with all of yourselves and with all of our partners who are involved to consider. So for example, based on what we know so far, we could take on some work around secondary school food. We've had amazing success in Newham around primary school food, and that's something that we think could be a real game changer in the secondary school space. Well, Newham is a programme that's being launched in the summer, and that could be scaled up to be a whole borough, whole system approach around improving health and equity through the community, basically through community-based approaches and interacting with residents and helping residents connect to the different services that are available. So I'm not going to talk through all of those examples, but just to say on these that no matter what the actions are that we might put into the strategy, there'll be decisions to be made around what are the priorities. And so it will be really important for us to think about what are our prioritization criteria, how can we make sure that the actions that we take as a system are the ones that are going to have the biggest impact on health or equity. Coming back to the point that we talked about earlier around outcomes, we want to be measuring our impact and constantly improving. And so one of the things that we're proposing around the refresh is that not only do we have KPIs which will measure activity, but we also start to introduce some outcomes that we can start to track year on year. And some of those outcomes might be hugely long-term and, ambitious targets that we want to look at, but some of them might be a little bit more short to medium term that we could expect to see some change over a few years. So we'll be clearly laying out how we can measure outcomes as well as those outputs. And then learning from our practice is of course really key. One of the new projects that's being developed at the moment is to set up a Newham Centre for Health and Care Equity. And there's I've already heard in this meeting some lots of people talking about things that we can really link in with that. The idea is that it will help us to use more research and evidence in our practice, to build capacity, to work with communities around research and evidence and build capacity in the community, but really important. And then on top of that, really importantly, to learn from what we're doing, what works in Newham, and how can we use that learning to improve our own practice, but also to share it outside Newham with others. And so that will be a really key feature running through the 50 steps of how we're reflecting and learning and sharing. So if we go on to the next slide, please. This slide shows some of the tools that we have at our disposal as a system to influence health. And this is rooted in what the evidence tells us around the ways that we can improve health. So, for example, it's really important that we make our services high quality, and that includes services being equitable and inclusive. Workforce is hugely important, and we can develop a health promoting workforce. Using evidence and insight is absolutely key. Creating an environment and an economy that supports good health, so coming to that health in all policies concept. Commissioning the services that as a council and as a system we commission, we have huge levers there to make real change, and supporting that social movement, so getting residents and partners across the whole patch involved and engaged. So those are just some of the tools that we have that can help practically deliver some of the changes that we want to see. If we go on to the next slide, please. So again, a few points, and this is absolutely not exhaustive, around the approach that we might take. So in terms of developing the strategy, and then when it's delivered, residents and stakeholders are going to be at the heart. And by stakeholders, we mean everybody in this Health and Wellbeing Board and a huge number of people across Newham that we partner with and we work with day in, day out. We want this to be a strategy, as is the current 50 steps, that feels really owned by the system and by people across Newham. We've already talked about learning and reflection and using evidence to understand what works and what do we want to build on. And we'll be doing a really thorough process of evaluating our 50 steps progress so far to look at what has gone well and what can we build on. And we really want to build on the role of change makers as well. And just to say, change makers are people in Newham who are engaged and are motivated to make change. So in terms of the structure and the content, again, this is just some early thinking. I realise there's a few points. I've just noticed there's a few things that I thought were on here that aren't, so apologies. I'll try and remember them all. But we imagine that we'll keep 50 steps, partly because we have a brand. And so the 50 steps is known. So we'll keep 50 steps, but of course, what those actions are will change. We want there to be equity objectives in every step. So driving forward that concept that we want to be addressing health equity as much as addressing improvements in health. We want every step to be able to clearly state how is it going to be addressing equity and how is it going to be measured in delivery of that step. As I've mentioned already, we already have KPIs which measure activity primarily. But we want to be defining some more clear outcomes that we'll be measuring and then reporting. And it's really important for us to be able to explain how and why we think the action we're going to take will improve health. And it really is rooted in the evidence base, but I think being able to make that really clear to people will help to explain and bring people along on this approach where we're looking across the wider determinants of health. So we're going to be taking action in a whole range of different sectors and ways, but all of those ultimately are rooted in the evidence around the things that affect people's health. And the one thing that I did also want to note on here is that as a board and as a council, we have a responsibility around a joint strategic needs assessment for health. And in developing the 50 steps, a lot of the data and evidence work to assess need contributes to our JSNA. So in refreshing the strategy, we will be updating our joint strategic needs assessment as part of the process. So if we go on to the next slide, please. So this is a very high level timeline of how we imagine the work panning out. So fundamentally, we want to deliver a strategy by April next year and to launch the strategy in April next year. So at this point, we've started to think about our plans. We've started to engage with some people like yourselves around the ideas and what should be the key kind of principles and also the content that you'd like to see, as well as the process of how we go about delivering or developing the strategy. So we're going to start data and health, data and evidence analysis quite soon. From there, we have, as I'm sure everybody knows, there are 12 priority areas in the 50 steps, and each of those areas has a program board who oversee the delivery of those areas. So those program boards will be reviewing and evaluating their progress to inform the next iteration. They'll also be developing their ideas around the game changers, the things that I mentioned that are big ideas that could have a really big impact if we commit to them. We're going to be doing wide engagement with residents and with stakeholders, which we imagine will start early summer. And then by the autumn, we expect to have an early draft, which we can bring back to the board to share, just to give a sort of a shape of what's coming out of our engagement and our work so far and what the shape of things to come. And then refining the strategy and taking it to the relevant boards and groups before we launch in April. So that's a very high level timeline, and I'll stop there and happy to take any questions.
Okay, so questions, colleagues. I would say thank you very much. And in part, I think we've had some of the conversations in the earlier agenda item 6 when we were discussing the 2-year progress report. We perhaps not so explicitly, but we did. So don't be dissuaded. Silence. Okay, so I can't see, let me just double check on the, no, there are no hands up, Claire. So you've done an absolutely great job. 2.0 recommendations. The Health and Wellbeing Board is asked to note, support and participate in the 50 Steps refresh, noting that successful development and delivery of 50 Steps 2.0 will require the involvement of all HWBB members. Okay, before I say, I'll ask, does everyone agree? I should warn everyone that it will be a significant commitment, but a very valued one. And in the sphere of all things data, digital and technology, do not take 2.0 meaning slow and wait for 2.1 and then super speeding to 15.
Yeah.
Okay, cool. Right, so is everyone agreeable? Agreed. Okay, fine. Let's move on. Thank you, Claire.
Thank you.
Okay, we're now going to be moving on to, oh goodness, I am so sorry, everyone. Pharmaceutical needs assessment. And this will be taken by Jonathan Cox, is it?
Yes.
Yes. Hi there. Good to you.
Yeah, great. Thank you. So this is an item on the pharmaceutical needs assessment. This is another needs assessment, a statutory needs assessment that sits alongside the JSNA. It is just a requirement of all health and wellbeing boards to publish every 3 years such an assessment, which is really about a determination of our access to pharmaceutical services. It's quite a specific piece of work with legal implications, so it has quite sort of specific terminology, which all stems from the pharmaceutical services legal basis. So we've carried out a detailed needs assessment where we've considered our pharmaceutical services provision, and by that I mean issues like the prescription or the dispensing of prescribed medicines and access to medicines, essentially, is what we're talking about here, that the NHS England commission. So we've carried out this sort of detailed piece of work. We carried out extensive survey with our residents to inform the opinion that we reached, and looked at how people determined their access, the extent to which people felt they were able to access, and things like out of hours provision, particularly important, in the dispersal and range of pharmacies across the borough. So we formed an opinion in which we thought that the access had remained good and was adequate. And then we, as part of the statutory process, we then carried out a 60-day consultation on those on that position. We received, I think, 26 responses, whereby the respondents thought that the methods were clear, the conclusions were clear, and agreed with the conclusion. So then the overall conclusion we drew is that access remains good and sufficient. This is a very important point, because the comments and the conclusions of this needs assessment then are used by NHS England in any applications that come forward for anyone who wants to open or indeed change a pharmacy. So it's kind of known as the market entry regulations. So by making a statement that we think provision is good and adequate, then that has sort of implications to market entry. So that's a sort of an important point. Of course, with our rapidly changing population, we can reconsider and carry out a supplementary review and issue a supplementary statement at any point that we would like to. We don't have to wait for 3 years to carry out a P&A and again and republish it. So yeah, that's my overall summary, and recommending that the board publishes this P&A as it stands, and that we did find that our access to pharmaceutical services remained good.
Okay, so any additional questions or comments based on what you've heard and read? And can I just say it's a really fantastic piece of work and deeply interesting, and well done, Jonathan, and the team and people behind it.
Thank you, Chair.
Neil, any comments?
Yeah, just to reiterate that, and thanks again for this work. I mean, under the old sort of governance structures, the CCG had sort of pharmaceutical sort of representation. It's a bit like a discussion that, Wax and I would have for ages about where does primary care fit in with the new North East London landscape. And often sort of it's pharmacy services are, community high street provision. And, it's important, I think, that we see this in the context of the growing population and the accessibility, and some really good work that is carried out by people in terms of, the vaccination programs or the delivery of medicines to isolated individuals within my Plasto one, so that people get delivery, of medicines. There is a comment in one or two places, like, the pharmacist, there's always a shortage. Well, there's a real problem with supply of certain drugs and generics versus, all the rest of it. But I think where we do it well is in terms of the pharmacy, which is, they're longer hours than they used to be. They're doing more things based on, and I think their relationship, primary care colleagues agree with this. Sometimes it breaks down in terms of the admin stuff, but that might be true of any system, whether it's a council or whatever service we're providing. But in general, there's a better relationship than there has been ever before because of the workload pressures, not least on GP surgeries, that pharmacists can do some of that. So I think it's a good way of us just acknowledging the very good work that the pharmacists do, but bear in mind that if we're talking about 15-minute neighbourhoods, whether we're talking about 10,000 new police to Royal Docks, we do need the local pharmacy as well as the primary school provision or any other provision. So, thanks.
Okay, fine. Jonathan, would you like to comment back to that?
Yes, I think you're really right to highlight the essential role pharmacies are on our on our high streets and are highly accessible, trusted, and highly respected and used very, very frequently by a lot of our residents. So of course there are always great opportunities that for pharmacies to provide sort of further services. You might see from some of the comments around, people are always really interested in accessing things like just healthy lifestyle advice, blood pressure monitoring, minor ailments, all sorts of services like that. So I think there are, it's an important part of the way in which we can help alleviate perhaps some of our primary care pressures, and it's, I think, an important part of building into our ICB4 plan what our joint view for pharmacy services is. So as I say, it's a really vital way in which people access significant support for their health.
Okay, yeah. I've just got one quick question. So I appreciate that sufficiency has broadly been met, but I just wanted to pick up on the point relating to trajectory of population growth, not least recent census outturn, and whether or not the 2021, to what degree have you had time to really analyze the ONS 2021 census data, given that it comes out in waves or chapters? And then the other thing I just wanted to encourage reflection on is whether or not the footprint as it pertains to the pharmaceutical needs assessment is sufficient, given our 15-minute neighbourhood access to basic essential provisions, because there won't necessarily be a 15-minute equitable spread, and how will that be remedied, because that's a strategic priority of the council.
Yeah, so we considered access by active transport methods. So we have very high levels of our population can reach pharmacies within a short time by active travel. So to encourage the local community 15-minute neighbourhood approach, and that's certainly something that remains a really important principle. I think you're definitely right to highlight our information, understanding of our population growth, and obviously how census information is, as you say, in a way drip fed our understanding does change over time as that information gets released. So I think, and given the, some of the developments in particular areas, I think, it is really important that we remain alert to any feedback from residents that whether they can still always access adequately, in particular areas, such as like Canning Town, where we might see a lot more development. There are some areas where we might see more pressure. So I think it is in Newham, I think 3 years is a long time not to reconsider these impacts. So I think it might be sensible that we do review this and certainly home in on the areas where we know there's been the most change and just revisit. We could do some sort of local surveys just to test that out. If the data is pointing to certainly the population change we're anticipating, but I think that would be wise. I'd be happy to take that recommendation.
Okay, fine. So that can be fed into the recommendation, assuming that everyone agrees. Yeah. Okay. Fine. Any other comments? I can't. Hang on. Let me just check. I can't see any hands up. Nope. All right, so let's just move.
Just on that recommendation, sorry, there's a given expected population changes, we may wish to consider whether access to the remains good in the intervening period. So there's a caveat, I think, in stating that we would want.
So we will.
A supplementary.
Okay, so perhaps I just amend that to say we will. The board will. Has agreed to consider.
Yep.
Does that make sense?
Yeah.
Yep.
Yeah. Okay. So let's move to the recommendations on big page at number 324. Recommendations 1. The board is recommended to approve the PNA for publication and notes that overall access to community pharmacies is reported to be good. And 2, given expected population changes, the board will, hang on. The board will consider whether access to pharmaceutical services remains good in the intervening period before the PNA is due to be refreshed in 2026 through issuing a supplementary statement. Is that okay? Yep. Do we agree? Okay, thank you. And now on to send improvement update. I am going to be inviting Vic to introduce. And Vic, thank you so much for your patience, and forgive me if it's not you. Is it you? It is. Yeah, it is. Sorry, it's just I've got a different officer's name. Over to you, Vic, and thank you for your patience.
Not at all, thank you, and good evening, committee. So I'll just highlight some of the key updates in this report, just to take you through some of the key points. So I think specifically following the completion of the backlog, the backlog of education, health and care plans, which had not been completed, we are now seeing sustainable and positive improvement in the timeliness of the writing of education, health and care plans, which from a statutory perspective have to be delivered within 20 weeks. We've seen, as there's a table in the report, but we're seeing that sustainably above 80%, and notably in January, 100% of education, health and care plans were completed on time. And we continue to track that through the SEND Strategic Improvements and Outcomes Board, which is chaired by myself, and also through the SEND Executive, which is chaired by Director of Children's Services, Tim Aldridge. This has been helped by the improvement in capacity of educational psychologists as well. And we are now turning more of our focus towards continuing to see that improvement in timeliness, but also quality assurance and auditing of education, health and care plans. And we will be starting our first multi-agency audit, which will be working collaboratively with colleagues in health, but also colleagues with in care and education. And in May and into June, we will be conducting our first audit of that nature. That won't just be a one-off piece of work that will be an ongoing quality improvement engine that continues to live with the service, and will undertake a number of thematic audits throughout the course of the year. I think since the last update, there's also been the launch of the new Ofsted inspection framework, which came into effect on the 1st of January of this year. And we also saw the launch of the SEND and AP improvement plan, which was launched by the Department for Education. And we have reflected that in our new SEND strategy, which will be coming to Newham Cabinet in June for sign-off. That piece of work has been a significant multi-agency piece of work. We've met over 250 key stakeholders multiple times through that period, and are now settling on a final draft, which will be coming through very shortly. I think also, just notably in the report, there's been significant improvement in speech and language waiting times, which have reduced from 22 weeks to 3 weeks. And we've also seen a similar improvement in occupational therapy from 25 weeks to 15 weeks. And that's been a key priority for our colleagues in health, and we continue to monitor that through our governance. And we continue to see an improvement in the autism pathway, which, owing to some of the challenges through the pandemic, rose to 84 weeks, but has now started to come down to 62 weeks and continues to be a focus for colleagues in health.
Is that it, yeah?
Yeah, so happy to.
Okay, great. So let's open up to questions. Are there any questions, colleagues? After all of that waiting, Vic,
I'll come in with.
I'm gonna more questions. Go on, Councillor Neil Wilson.
Thank you. It's basically an observation rather than a question, but as a governor, you know, there's always been some sort of, you have to dissect at the governing body, therefore, you know, what has been a national issue about, you know, higher needs funding and all of that. I speak as a chair of FARNets of two governing bodies at the primary level, but you know, how you dissect that from a historical backlog and the fact that there are shortages within occupational therapy across the health piece, and particularly in educational psychological services. And then my other point, Chair, was about to make reference, because we're short of time, and I'm sure it's just important to note really for our minutes that in 3.28, public health colleagues continue to lead on the development of a SEND specific needs assessment by enhancing projection data and working with delivering better value program, particularly in relation to autism spectrum disorder, because I think whether it's at school level, I speak as an ex-teacher, or within society generally, I think we've got a long way to go in terms of understanding the scale of the issues, but particularly for children who are more and more presenting as being on that spectrum. So it's really about, you know, how that is a really helpful, I think, way that we can, from the health perspective, help this, as well as the statutory partners who are involved.
Okay. I'm gonna, did you want to respond to that, or I was going to invite Vic? Okay, I'm gonna ask Vic to respond to that first, and then I'll come over to you, yeah?
Yes, so I think there are challenges in many paediatric therapy, so such as speech and language, occupational therapy, educational psychology. That's a combination of fewer young people taking those as qualifications at university, and some of the challenges around the supplementary grants that they receive to take on those professions. So we see that as a national challenge.
Yeah.
And I suppose we are thinking about in our recruitment, and we've been quite successful in some of our recruitment, but fewer numbers coming through. So I agree with the point. It continues to be an area of focus for us. I think on the points around autism awareness, absolutely, in terms of working with colleagues in health and public health, we're starting to do some deep dive work in understanding that data more, We are seeing a rise, so more of our children are identified at 2 and 3 years old, which is really positive and exactly when we would want to be seeing those young people. So the system is working in that respect. And I think there is a greater societal understanding of autism. So it continues to be an area of focus under our strategy, absolutely, and how that can be supported in schools in their learning.
Okay, thank you very much. Over to you, Colin.
Thank you very much, Chair. Thank you, Vic, for the report. In terms of obviously reading the report and the reduction in the EHC plans backlog is very commendable. But I am interested in how you sure or how we are assured that those plans are of a sufficient quality in terms of what's being as an output. So I'd just be interested to know a little bit more about how we're assuring ourselves around that quality aspect.
Okay, Vic.
So this, I think, comes back to our work around our quality assurance framework. So we published that in the last couple of months, and we'll be starting our auditing process. And that's a comprehensive, I suppose, comprehensive quality assurance framework in that we will not just look at the education, health and care plan in terms of the quality of what's written into it, but also meet with families, meet with SENCOs at school to triangulate what has been the experience of that family through that process. We will do that in a number of ways. We will look at particular demographic parts of our children and young people with education, health and care plans. So could be particular ages and phases that we are focusing in on, but also with a thematic view as well, where we look at particular areas of need, and that will be part of our roadmap of quality assurance. The aim of that is to then build not just learning for the individual cases that are audited, but actually learning that can help practice improvement both in our frontline work with the SEND service, but also thinking about our partners in health and in social care and the learning that can be derived across the system. And that would be part of our service structure, working with colleagues in the quality assurance team in children's services, and will be an ongoing and iterative process that drives better quality across our system. So that's one part. And then obviously through the SEND strategy, we've developed an outcomes framework which will help us to assess, I suppose, the distance travelled in the changing experience of our children and young people and their families, and that will be published as part of the SEND strategy, and will inform our various engagements with families, our surveys, both at individual points, but actually at key points through the year.
Okay, yeah.
Sorry, Chair, I could add something. Yeah, absolutely sort of agree with the points Vic's made. I think there's also a real focus on developing better quality practice. We brought plan writing back in-house. It was previously commissioned out to another provider. And it's really about a cultural shift across the whole of the SEND service and across the partnership as a whole, whereby we are working with families to co-produce plans and to review together the achievement of those outcomes that are set out in the plans. We're also looking, and Vic mentioned earlier, about what is it that we can do to mark Newham out as a destination for those professionals who work in this area. So again, drawing on sort of other improvements across the council to think about how we set out the opportunity to work in a more innovative way, and in particular thinking about some of the work we're doing on family hubs, on locality working, on more integrated working across agencies. How do we really sort of shine a light on that offer and make it a real attractive place to come and work?
Okay, great. Mumtaz.
So I'm really impressed looking at before, and I hope that the implementation of it, we will soon see. I'm kind of going back to Colin's point about the quality of some of the assessments. I'm coming from a background where I see some of these assessments where the language that's used in reports are not very understandable by families. So I'm just, it's like a suggestion really. I'm not really asking a question. I would like to see better quality of assessments where parents can read and understand. So, you know, using things like language that really cares.
Okay, did you want to respond to that bit?
Yeah, I would agree that plans in their nature and in the statutory nature of them are not always as accessible to families as we'd like, and I think that's part of the national picture as well. One of the things we'll be looking at developing in the autumn is a step in the process fairly early on when we've got the advice from various professionals, but also as we develop what's called Section A, which is that first part of an education, health and care plan, where a family, a parent and carer, or a young person can contribute to what their views are and what they'd like to achieve, and work together with families early in a co-production meeting where we assimilate that and write the plan in a parent-friendly way, and in a way that they would want it written to represent their young person. I think often the feedback, you know, we get from families is that the plan doesn't feel like it represents the child, and I think that's something we really want to work on. But we know that's best, you know, working alongside families and representing that view as we write it in a parent-friendly way, but also a SENCO-friendly way, so that schools can use that as well.
Yeah, I've just got a couple of quick questions. Just noting the some of the data that's been presented in the report. Could you just provide an explanation for some of the fluctuations in the table just under 3.9 on big page number 493? I was particularly struck by the achievement of 100% January 2023 in terms of new transfers within 20 weeks, and then it dipped in the subsequent 4 weeks to 78%, and then it's jumped back up again. What's driven that? I'm just assuming resource capacity, i.e. people have just been ill or holiday or something.
I think there's an element of I suppose I'd call it kind of seasonality in terms of the levels of demand and how they flow through from schools, and when those then land. Sometimes there are delays in the advice being received from professionals, and that can also involve the information being received by schools as well, where they're supplementing a request for assessment. So possibly also combined with some of the pressures on the service. So what we have seen is that, I suppose for the first time, we are sustainably and in the main above 80% on average. And that's a positive space to be at the moment in comparison to the national average, which is about 59, 60%, I think, from the figures from 2021 that we have published. So we're seeing improvement. We're feeling that that's sustainable improvement, and we're certainly feeling that the families where there are delays, we have communication lines open with them in terms of the reasons for those delays. So certainly more to do there to continue to see that improve and sustainably stay at 100%. But there is an element of the demand fluctuation as well, with the points at which SENCO send those in.
Okay, and then where it talks in 3.7, significant increase of 723 children join the EHCP population, which is the highest increase in a calendar year since reforms were introduced. What, in Newham, or how does that compare to the rest of London or comparable borough?
I can make a start. And
yeah,
to come in. I just want to make a point on that previous question you asked, Mayor. There's often quite a fluctuation in numbers per month. So those EHC plans in January, for example, were the request was made 6 months previously. Okay. And sorry, the numbers aren't in the report, but we can furnish the committee with them if that's helpful. So, for example, in January there were 9 In February, there were 27, and therefore there are some differences in volume. I'm sorry, just remind me, Mel, what that's like.
Oh, it was just, is the 3.7 that's the highest increase in
in
Newham. How does that compare?
So Newham was relatively slow rather in implementing the 2014 reforms, which meant that we have a relatively small percentage of our school population who have an education, health and care plan. So although the number in the last calendar year is high, and it's the highest it's ever been in Newham in terms of new plans, we're in a sense still playing catch up to some extent with other places who have a higher overall proportion of children who are subject to HCPs. Now, that's not a target to aim for, but it's, I suppose, a reality that in Newham for a longer time, we've had children and young people who would be sort of eligible for an assessment who previously haven't received that assessment. And perhaps the message to schools and parents was that there was a different way of getting your needs met, whereas more recently, we've clarified the importance of those who are eligible and who require additional support going through that assessment process. But Vic, I don't know if you want to add anything there.
Yeah, I think there's, I agree in terms of the backlog and the delays in implementing those plans. I think that makes up the majority of that growth. I think also national average has been steadily decreasing, but started at almost 20% increases year on year. In the early years of the reforms, it started to climb down. I think in 2021, it was around 10 to 11% nationally. I don't have the figure for London, but I can certainly look that up. And I think there was a more modest single digit increase in 2022. So I think there is a declining increase in the number of children and young people with education, health and care plans, but we will likely see that increase slightly higher than national for a period of time while that kind of levels off. I think on the number of education, health and care plans issued within 20 weeks, the national average from last calendar year was about 59 to 60%. So just as a comparison for the data we've presented.
Okay, and then the report's peppered with risk terminology in certain sections. In the context of the risks identified, do the Health and Wellbeing Board need to know about the efficacy of the partnership response to what's been identified in the written statement of action and what we said that we will do? Are we going to meet it? I just think it's important that we ask that question so it's logged. And I noted the system risk, significant technical challenges with the case management portal. And at what point will you pull the plug on the provider?
Can I start, Roxanne, and I'm sure Vic will want to come in with a bit more detail, but no, absolutely, you're right to pick up. There are risks involved. I think when it comes to meeting the requirements, the written statement of action, I think broadly we are able to mitigate many of those risks. I think he flagged the issues with the implementation of the case management system. I know Vic will respond, and he is closely monitoring implementation, and there's a decision point coming up very soon around whether we pull the plug, as you say, and need to seek a different solution. But I know there's a lot of workarounds going on. The other sort of challenges relate to both the provision of specialist services, as has been flagged already, and sort of the ability of us to recruit to particular professional groups. So I think as far as the written statement of action is concerned, we've made really good progress, and we've had some very helpful, positive feedback from the Department for Education and NHS England. Of course, the goalposts have shifted somewhat by the publication of a new Ofsted inspection framework and also the publication of the SEND and Alternative Provision Improvement Plan. So Vic and his team are reviewing where we stand in relation to those new requirements. We have an annual engagement meeting with Ofsted and CQC in May, and I think we'll be in a good position to report back to the board next time we present on that updated risk assessment in relation to some of the changes of requirements. But Vic, I don't know if you want to add anything in terms of your position on that.
I think that covers much of it, and I think the SEND Strategic Improvement and Outcomes Board, which monitors both the response to the written statement of action, but also our preparation for the reforms that have come into play, meets on a three weekly drumbeat, and that's attended by colleagues. I know Marie's with you in the room as well, and jointly with colleagues in care. We monitor that in all aspects, and that's been a helpful pace to set, I think, in terms of overseeing that work, and then we report into SEND executives. So risk is certainly escalated in that respect. I agree with Tim in terms of the DfE have been positive in terms of progress made at the last meeting, and I think we're now looking to kind of start to develop our kind of impact strategy and looking at how that impact is captured and measured in terms of change in lived experience of our children and young people that are coming through the system now. So I think that probably covers the main points, but happy to speak further.
I'm just also concerned about the underdevelopment arrangements for Joint Commission. Well, it's an improvement area. I appreciate that there's been conclusion of the understanding of, the assessment and understanding of the need, but where would that sit in the risk measure?
Yeah, if I can come in there, I don't know if Marie might want to say a few words as well, but there's been, you're absolutely right, Mayor, that was a risk that was identified, or a gap that was identified in the 2021 joint area inspection. There's been quite a significant amount of work to look at joint commissioning arrangements. We've strengthened some of the commissioning resource in that area, and we're reviewing further to see if we need to strengthen it further. And there's been some really effective joint work, particularly around speech and language therapy, where there's been agreement in principle around a new approach to integrating the services provided. There's a regular operational and a strategic group that reviews progress in that area. So I think more to do, absolutely. It's not a quick fix, but there is progress being made. And again, we report that on a regular basis to the DfE and then NHS England.
Okay, fine. Are there any other questions or any other comments? No, I can't see any. All right, so colleagues, we're going to note the let me just quickly recommendations. So page number 1, Wellbeing Board are asked to note the progress made against the written statement of action and the areas of risk and challenge presented within the report. Have we noted?
Yep.
Okay, thank you very much, and thanks Vic and Tim and the wider team for all your hard work in this very important area. And on that note, just wanted to advise that dates will be circulated, a date of dates for the next, which will be in 2 months' time. And thank you so much for your patience, and apologies that we are 45 minutes over the timeline that I'm supposed to be, that was suggested to me that I follow. Okay, goodbye everyone.
Thank you.
Bye.
Thank you. That's